Thank you very much. It's a thrill to be here. I really, before I go, I want to sit in that chair. I don't know if that's allowed or not, but I'm hoping. I'm going to talk to you a little bit today about personal genomics, which is a pretty exciting area. And I'm going to try to go quickly so we stay on time and take you through sort of a whole range of ideas. And then hopefully we'll have some discussion at the end because it's such a fun area. Now, academicians are expected, although we definitely have our own academic self-interest, we're also expected to try to be the honest brokers of a lot of different commercial interests. So it's important that you know when we are in any way involved with industry. So I am involved at some levels with industry. These are my disclosures. In addition to the research grants, which support most of our work, I do some compensated work for these companies, and we've had uncompensated research affiliations with several of the direct-to-consumer companies. So the question, of course, where we all want to go is how are we going to use genomics to improve human health? And as you're going to hear today, as I fly through a kind of summary of it, there's an enormous amount going on, but that last mile to get it to the patient is still pretty tricky. Now, many of you are studying genetics, so this is going to be obvious to you for a second, but I think there are people in the audience, I was told, who are not. So just a quick reminder of how far we've come since Gregor Mendel. We know that there is a DNA molecule with 46 chromosomes, 2 meters of DNA in every cell, 3 billion letters that make up each and every one of you, and of those, only about 20,000 genes. And we know that there's this sort of entire genome that we talk about, and we kind of abbreviate that when we talk as a whole genome. And then we often talk about the exome, which is just those genes which are coding for protein. And it's even smaller than this representation. It's about 2% of the genome. And then in medical genetics, we have been sending single gene tests or panels of tests for actually quite a long time. And so we've been thinking about genes kind of one at a time. What's really changed is now that we're thinking about genes all together. And that really is genomics, epigenetics, metabolomics, proteomics, all the omics. I mean, is just the big scale. Of these 1,000 genes, there are only about 5,000 of them that are known to be associated with human disease so far, though we're discovering them more all at a time. And of course, if you spread your DNA out, if you looked at all the letters, they'd just be a bunch of T's and A's and G's and C's representing a chemical alphabet, which creates an enormous set of books, if you will, book of life if you're being poetic, and all the things that make us different from each other, both in terms of traits and in terms of health, are at least fundamentally coded at this level. Now, what that means in real life is 99.9% exactly the same. You look around in this room, regardless of your gender, your color, your hair color, your eye color, your skin color, whatever, and you're almost exactly identical. But there are these places called variants where we're different from each other. Variants are completely harmless. Some of them relate to our ancestry. Some of them control traits. Some of them are associated with diseases, and a few of them are, in and of themselves, devastating causes of diseases. And those we sometimes call mutations, although that word is kind of going out of fashion. More and more now we talk about pathogenic variants and benign variants. So, sort of like this, there's variants scattered throughout the entire genome. And then early on in genetics, we recognized a few of them as being particularly damaging. And so in traditional genetics, we've got the traditional dominant Mendelian heritability pattern, with the fundamental disease being Huntington disease, for example, where one individual has it. If they have the mutation, you're definitely going to get the disease, and there's a 50% chance of passing it to your offspring. If you have it, you definitely get the disease, and so forth. And then we have our classic Mendelian recessive condition, where each parent carries one copy, but the child only gets it if they are unlucky enough to get both copies of the mutated gene. So this is our classic dominant, our classic recessive, and then our classic X-linked. But what's changed is that this only represents now a very small fraction of what genomic information is all about anymore. It was the end-all and the be-all when we started. We thought this was what genetics was, but it is actually much, much more subtle than that for the entire rest of the universe of genetics. It turns out that classic dominant and classic recessive, with their full penetrance, meaning if you have the mutation, you definitely get the disease, are rare exceptions in the world of genetics. And almost everything else is probabilistic. We'll talk a little bit about that. So technology, of course, is part of what's driving this, and it's really changed our approach to genetics. Maybe 10 or 15 years ago, people started making these chips, and you could, suddenly, for a very small amount of money, you could look at hundreds of thousands or even millions of these variants along the way. The only thing was you had to actually kind of know that a variant was there in order to look in that place. So think of them as signposts. And there were lots of situations where you could take a whole bunch of people with, let's say, multiple sclerosis and a whole bunch of people without multiple sclerosis, and you could run these chips on them, and you find out that a particular variant was a little more common in the people with multiple sclerosis than it was in the people without multiple sclerosis. And when you did the math, it was statistically significant, and it turns out that that was associated with multiple sclerosis. So it didn't really cause it in the old Mendelian sense, but it was associated with it. It was a risk factor for it. And indeed, this has gone on to, we've done this with hundreds of different conditions and traits. So we have across your chromosomes, there are literally hundreds of markers that we now know are probabilistically associated with pretty much what you can think of. Height, obesity, hair color, disease, diabetes, heart disease, multiple sclerosis, everything. And all of the genome-wide association studies, or GWAS studies, that have been going on. And so this has been reaching a field doing GWAS studies when sequencing itself reduced in price. As you've all seen those graphs where it reduces in price faster than Moore's law. I won't show you one of those. But here's sort of a play on it, where it cost about $3 billion to sequence the first genome, and then a few years later, Nome or Nomi, depending on how you pronounce it, was selling them to wealthy individuals for a couple $100,000. And then over the last few years, they've come down. If you want to get your whole genome sequenced today, we can arrange for you to do that for $2,900 and have a valid medical report of it. And it's pretty clear in most of the minds of my Silicon Valley colleagues that this is continuing to plunge, and you'll get your whole genome sequence as a giveaway when you sign up for a magazine subscription or open a bank account, or pretty much just as a loss leader for any kind of business that maybe for a gym membership, you get your whole genome sequence. In fact, it'll become so cheap, it's going to be cheaper than even storing the data. You'll probably just get your genome sequenced every time you walk into the hospital or your doctor's office, because it'll be that fast and that easy and that much more accurate. This is a little cute thing you plug into your laptop, put a drop of blood in it, and it'll sequence it right there, probably by the time I'm finished with this lecture. So, when we talk about genomics in medicine or in health, we're really talking about a lot of different categories, and I'm not going to touch on them. We're not going to touch on them all today. We're going to touch on just a couple of them. But my colleague up here, Pat, is going to talk about cancer treatment. But I want to be aware that there's all these different categories, and the rules and the utilities and the problems and the scary things, they're all different in each one of these. So you really can't sort of think of genomics as a whole. You've got to think of it as these very different arenas. Non-invasive prenatal testing has caught on faster than almost anyone imagined, because you can take the mother's blood and actually get test for aneuploidy in the fetus. And this is caught on because nobody wants to actually have a needle placed in their womb to get amniotic fluid anymore. In my world of medical genetics, sequencing is catching on very fast for mysterious conditions, mostly in children, but even sometimes in adults. Somebody comes in and they've got a syndrome that you just can't figure out, and you've never seen anything like it before. One of the tools we now turn to is whole genome or whole exome sequencing. And I'll tell you a little bit about that. But we're also very interested, we'd love to know the future, we're also very interested in predispositional testing. What am I going to do? And you both in the Mendelian arena with these sort of Mendelian diseases like these cancer predisposition syndromes, Huntington's disease, BRCA, but you can also do it with all those GWAS things I was telling you about, where you can actually see what kind of SNPs or single nucleotide polymorphisms you're walking around with, test them, and actually give you a kind of readout for what you're at increased or decreased risk for. And this is, of course, what the direct-to-consumer companies have started with. And then there's also carrier traits. What are you just walking around carrying as a recessive trait that's not going to bother you at all, but if you should happen to breed, I believe is the technical term, with that same mutation, then you've got a 1 in 4 chance of having a child. Right now, we're leaving that to chance most of the time. Should we be leaving that to chance? A lot of people are arguing, no, we all know what carrier traits we're walking around with. And of course, pharmacogenomics, turns out that some people with a particular genetic profile do better or worse with certain drugs. You can't really imagine a future where that's not going to be part of the dispensing of medication. So lots going on. I'm only going to talk about a few places like this, which are what we're working on. And by the way, remember that almost this can take place within medical practice, and almost all of it could take place in a direct-to-consumer realm. And I guess one of the things I'll challenge you to think about is there a right and a wrong in this? Or like network television to cable TV, people are just going to have more choices about the way they get their entertainment and news, and some people are going to select to do it in a medical world, and some people are going to select to do it in a much more self-empowered world. So one of the things that traditional genetics, because it started with fully deterministic, dominant, and recessive conditions, because those conditions were at first devastating, fatal, completely horrible, and because so many even of the recessive conditions happened around birth and reproduction, and you had to decide under pressure if you were going to terminate a pregnancy, because these things were so charged, we started off thinking about genetics and the information you get from genetics as very frightening, very disturbing, very potentially damaging. And I don't clear about this. There's still situations where this kind of information is absolutely devastating to an individual or a family, turns their world upside down. And we, in the words of Les Biesecker, we're the only discipline that appears to be afraid of our own technology, and that's changing rapidly too. And so the program that I direct is called Genomes to People, and it's a cheeky name that sort of says we're interested in what outcomes, what are the real outcomes, not the hypothesized outcomes, not the feared outcomes, but the actual evidence-based outcomes of using medical outcomes, behavioral outcomes, and economic outcomes. Now let's start with a real simple example. Let's start about, there happens to be one of these markers that if you're at risk for developing Alzheimer's disease. Scary disease, no treatment in sight yet. It's pretty much been that way for a while, and this marker really is an authentic risk. In fact, about 24% of the people in this room, let's just say everyone, has a copy of the E4 allele, which puts you at increased risk for developing Alzheimer's disease. And about, let's say the 4 people on the front row over there have 2 of this allele, puts you at about 30 times the risk of developing Alzheimer's disease. So, let me ask you, how many would like to know your ApoE genotype and know if you're developing Alzheimer's disease? Raise your hands. Higher, Great. Great. Your hand up. So if you actually do people to learn this under extremely controlled circumstances, what will they do? And it turns out that a lot of people did want to know. A lot of people who have put their hand up went ahead and learned. We put a research study called the REVEAL study where you actually randomized them like a drug into one arm that got the information and one arm that didn't, and then we saw what happened. And basically what happened was that if you the groups, one of the people who put your hand up, you do well with this information. Turns out people who were E4 positive, once they had sought out this information, were no more depressed, anxious, or distressed. In fact, there was a little overall benefit, particularly for the people who learned they did not carry the E4 allele, and did adjusted to it just fine. So-called untreatable disease, people did things with the information. There's this whole myth of actionability that says if we can't give you a pill for it, there's no reason to test for it. People don't feel that way. People were curious, people wanted to know. When they learned they were at risk, they tended to take vitamins, increase their exercise, change their diet. And actually put some numbers to this concern that the insurance companies had for a long time called adverse selection. And indeed, the people who learned they were E4 positive were much more likely to report that they were purchasing long-term care insurance, which makes perfect sense if you're a client. It's pretty scary if you're an insurance company. We then moved on, and we actually did this for 15 years. There's 4 series of REVEAL studies that I could spend all day telling you about. If you invite me back and want to hear, I'd love to. But we also moved on and got an NIH research study to study direct-to-consumer genetics. And most of you have heard of the companies, at least one of the companies that's doing this. How many of you have done direct-to-consumer genetic testing? Usually 23andMe. Okay, got like 2 people. Okay, so as you know, you spit into a tube and you send this to them, and then they do all those SNPs I was talking about, all those markers, and they send you back a report that tells you a whole bunch about your traits and your ancestry and what percentage Neanderthal. My wife was really proud that she's about 2.9%, and I'm only 2.2% Neanderthal. And before they were asked to stop giving their health work in November 2013, you'd get back a lot of health stuff like this. And the criticism of direct-to-consumer genetic testing came from a lot of directions, but I think the most valid criticism was that the effect size of the information they told you was often extremely modest. So sclerosis there, and you can see that is 37% elevated. All right, that can sort of sound like a lot. But if you, and they did, to their credit, they changed their readout to make this more obvious. What that means is their estimate of the average population risk was less than 1%, and is still less than 1%. So I went from less than 1% to less than 1%. Not too crazy there. And the concern was misunderstanding. The concern was that people would understand that the way that the risks were supported, and you can see that kind of moving up here, it starts to change. I go from 1.6% for Parkinson's disease to 2.2%, so forth. So it really wasn't not that helpful in terms of reclassifying people and changing perhaps your medical strategy. But of course, this isn't why a lot of people want this information. They're very curious about it. To become questionable, this is my results again. And you can see that according to them, my average risk of atrial fibrillation is 27%, and push it up to 34%. Well, there's also some controversy about exactly how they calculate these numbers. So it's not clear that it's right, but it's interesting, and it might make me think about things that I wouldn't ordinarily think about. I'll tell you one thing. It turns out they're the only ones who told me in all of my years going to doctors that I have factor V Leiden. About 5% of you have factor V Leiden, which is a fairly common variant that means your blood clots faster. And sure enough, they picked that up, and mostly because of that one variant, they say that I've got a rather dramatically enhanced risk of thromboembolism. So I'm leaving here today a little early, I'm sorry, because the discussion looks good, but I'm going to get on a 6-hour flight, and I'm going to stand up and walk around more because they told me that my blood is at risk for clotting. And you know what's funny? Every time I do this on a plane and I go back to the galley and I'm standing there going like this, you know, back in the galley, there's always one other person back in the galley. I get to talking to them. There's a frighteningly high percentage of people who had thromboembolism and pulmonary emboli who stand back in that galley doing this with me. I don't know what it is. I guess once they get that clot, they don't want to get another one. It kind of brings home to me the fact that I don't want to have that. So I don't know if it's helping or not, but it's something I do. Now, there were a lot of concerns that there's some pharmacogenomic variants in these, and that there was concerns that people would be changing their own medicine without asking their doctors. We've surveyed close to 2,000 of these customers, and they actually, or at least don't report, that they're changing their meds without consultation. And there was also concern about false reassurance. I tell you that your risk of diabetes is actually quite low, and you say, pass me the jelly donut. It's the jelly donut effect. And we found that there was nobody who at least admitted to this. They all said, actually, the opposite, that because of the sort of they were getting, or the focus on their own DNA, they were actually doing increased dietary or exercise change. Nonetheless, after 700,000 people had experienced this testing, the FDA shut down the most prominent direct-to-consumer company in 2013. I was actually one of the only geneticists in the world that said, guys, it's a little late. There's 700,000 people who've gotten this. We haven't seen a lot of harms. I think it's a little late to exert the precautionary effect at this point. And indeed, that company, 23andMe, just worked their way through the FDA approval process and have come out with health variants once again, starting with recessive carrier traits. So if you do purchase the service, you can get that. They're still working their way through the pharmacogenomics and the common complex risk variants. But I guess I'd like to go quickly now to sequencing, because that's sort of the hot thing that you're hearing about, right? Exome and genome sequencing. You're going to hear more about it in cancer. What does it mean for you in your life? Well, one of the things is that if you do have a mysterious illness, we have a better chance of finding out what it is. Turns out, and if you're interested, that we've summarized sort of how to use sequencing in this manner when you're facing undiagnosed disease. And it turns out that there are situations where children or adults present. For example, this is Nick Volker, a little boy whose story has been told many times. You might have heard about him. He had this terrible GI disorder where he could not digest any of his food. And he was literally dying from being able to not digest food. And tubes in him, and we're feeding him intravenously, but you can't go on and do that forever. These kids die. And in a sort of Hail Mary kind of way, I am at Villanova, they sequenced his entire genome, and they found that he has an XIAP mutation. I wouldn't know what this is off the top of my head. You look it up, it's associated with a rare autoimmune disorder that can be treated with a marrow transplant. He was marrow transplanted and had an extraordinary recovery and is doing well so far. Now, turns out still is the exception, because when we find these diagnoses with sequencing, we usually find a treatment for them. In fact, I can count on one hand the number of times that I've even heard of people making. So I don't want you to get the wrong idea that it's always sort of a miraculous. But finding the diagnosis itself is huge for many families. It ends what they call the Diagnostic Odyssey, where they've taken this kid with a mysterious illness from doctor to doctor, medical center to medical center, helps them plan their future if they want to have more children. It helps them understand if there's something running in their families that their children and their children's children should know about. So it's really important, although not important enough to be reimbursed right now by insurance. But raises something else. If I do your whole genome, Pat, then I may be looking for a heart problem, but what happens if I happen to run across a gene variant that puts her at risk for cancer? Do I tell her? Do I ignore it? Does she want to know? So this is the problem and the opportunity of incidental findings. And I was charged with leading a working group to try to standardize this as sequencing was getting launched in the medical world. And we spent 18 months putting together a set of recommendations. And I knew we were on the right track when we didn't please anybody. People hated them because they were too expansive, or they hated them because they were too restricted. At any rate, we came up with genes representing 24 rare conditions that we, and you know what the criteria was? It wasn't all these. We at night if we for you that you mutation. That ultimately came down to be our criteria. But if you are a 9-year-old girl walking around with a heart problem and we sequence you, and we can't find the etiology of your heart problem, but we find that you have a BRCA1 mutation. There are 2 reasons why we need to tell you that. One, your mother may have it, and your mother may wish to live. Number 2, we keep track of that little girl, and somebody in the family ought to know that that family is carrying that mutation so that people who want to be tested for it and want to learn about it can do so. Now, a lot of people don't agree with that. They're worried about the right to an open future, the idea that you shouldn't have to learn scary information, especially probabilistic scary information, if until a certain age or until we're sure you want to do something about it. But you know, it really brings up what's the right analogy here. How many of you bicycle around campus or to work or for recreation? Come on, I know you bicycle. Put your hands up. This is the part to keep you awake. Good. It's after lunch. All right, so you fall off your bicycle, you go to the emergency room, you're worried you've cracked your rib, you get a chest x-ray, right? Your ribs are fine, but shadow on your lung. Now, do you think anybody's going to sit down with you before you walk in to get that x-ray and say, well, Pat, before you get that x-ray, I really like to talk to you about all the things we could discover that could be dangerous. Now, right now, I don't know. That is. That could be an old TB scar. It could be an infection that means nothing. It could be the start of cancer. It could be a metastatic cancer. It could be a lot of things. I have no idea. I haven't contextualized that with knowing about whether you smoke, whether you've had foreign travel, anything. But it's a clue, and it really ought not to be ignored. And a lot of us are trying to think about genetics, defunctionalizing genetics and making it just part of the practice of medicine. However, others have a point, and that point is this. We used to throw people into whole body scanners. And when we did that, we would find all sorts of things. We'd find little white spots here and little shadows there. And so then suddenly they'd find themselves on the operating table, and some surgeon would be digging into them after something that never was going to be a problem. So there are downstream consequences to excessive screening, and we have many public health examples of that. So there is a point to be made here. But still, on the whole, I feel that genomics has strayed too far in the exceptionalist direction, and we need to bring it back some. I also want to make it clear that the 2 things that we're using sequencing for most right now that I don't think anybody argues are legitimate, are diagnostic sequencing, like I just told you about, and sequencing for cancer treatment that you're going to hear about. And different than saying, let's sequence everybody in this room and see what we can find. Okay? Remember, those kids or those adults have something. They have a disease. They have a prior probability. You walking around here are generally pretty healthy, or if you have something, you know why you have it. You don't have a rare genetic syndrome. But people are going to want to know. And it's going to be so easy to get this. And so many companies are going to be selling it in different ways to you that it's going to be hard to resist. We have a project called the Mendel Project, in which we're trying to prepare doctors who are faced with this flood of information. And we generated 2 of patients with a hereditary disease, in this case cardiomyopathy, and patients who are ostensibly healthy, like hopefully most of you. And we randomized both of them to get whole genome sequencing or a regular standard of care. So a randomized trial again, just like we did way back in the REVEAL study. And we're following them through for a highly granular set of outcomes, medical outcomes. Now, we don't expect a lot of medical outcomes. We actually could do them harm, right? I mean, we find that somebody has a genetic variant for a long QT syndrome. It starts a cascade of workup. They go to a cardiologist. They get really nervous. They get an implantable fibrillator put in. They have a reaction to the anesthesia and die on the operating table. Right? And had a problem with their heart. So we're looking at outcomes, but we could also catch things. We could catch the people who are walking around with a cancer predisposition, get them to do surveillance earlier, maybe save their lives. Only about a third of you put your hands up for ApoE. Let's take a poll now for whole genome sequencing. Now that you know all these different things you could find, how many would like to, let's say it's free. So we'll take the cost issue out of it. How many would like to have your own genome, whole genome sequenced, and get it analyzed and reported back to you? Okay, wow. Almost more people than the ApoE. Perhaps because you think there's more that you might find that's useful. Well, it turns out that if I ask that question of you and tell you in no uncertain terms that we're putting the results in your medical record, it starts to inhibit you a bit. And that is because we found out there's still an enormous fear of insurance discrimination out there. It's really, really strong. In fact, of the people we started to recruit for MedSeq, quite a few declined when we were actually sitting down and talking to them, and the most common reason for declining was fear of insurance discrimination. But we've persevered, we've pursued this, we've enrolled 200 people in this, and we're following the outcomes. One of the innovations we did was a one-page whole genome sequence report. So I don't know if there are any doctors in the audience, but one of the things you might think of is like, oh my God, how am I going to handle all that information? Well, we're trying to make it easy. You don't have to be a nuclear physicist to read an X-ray report. You just get a report. It's been kind of massaged for you to make it usable. So we've tried to create a usable whole genome sequence report for the average doc. And then we tested this with average docs. We got a bunch of primary care doctors. Now, obviously, they're volunteers, so they were enthusiastic. They're not necessarily representative, but they were primary docs. They had no training in genetics, and we gave them 6 hours of orientation to these reports, and we've been audio taping every word they say to their patients, tracking their orders in the medical record, interviewing them and the patients afterwards. And again, holding our breath a little bit, but nothing bad's happened yet, and nor have they made just errors in talking to patients about this. And we're doing really cool things, because we're realizing that our variant classification, which is part of the trickiest part of this, is good. And when we 4,600 disease-associated genes, we're finding that all in this room is carrying at least one recessive carrier trait. Did you know that? Did you know all carrying a recessive carrier trait? It's just dumb luck that when you reproduce, you know, you don't have devastated children. And then a striking 20% of us are carrying traits or carrying variants, what we used to call mutations, in dominant conditions. Now that was crazy. So they're really rare things. They're things like heart problems. They're things like white spots in the back of your eye. They're things like inherited hearing loss. But 20% of us are walking around with them. This poses an opportunity and a problem. The opportunity is that there's a lot of symptoms out there and signs that are unexplained. When we're digging in, we know that there are folks who were the eye doctor for years. There were, yes, white spots in the back of his eyes, and nobody could explain it. And there's a genetic disease that's associated with this. A man with hearing loss at a young age, and sure enough, he had a mutation in a hearing loss gene. So were previously unexplained. But we're seeing lots and lots of conditions where there's no apparent phenotype whatsoever. So this is a problem of penetrance. What probability that you have the disease or develop some aspect of the disease. And we're creating a whole new economy of disease. It's not whether you clutch your chest, fall to the ground, and have a heart attack. It's about the chance that calcium buildup of plaques in your coronary arteries on their molecular basis rather than on their end-stage symptomatology. And that's incredibly exciting, but it's a lot of work between here and there. Be a pun answers, so everybody turns tomorrow, gets sequenced, gets a responsible report back. Well, from my point of view, first of all, from an entertainment, I think it's fantastic. I think people do whatever they want. But we've got a responsibility to be a little and talk about clinical. This is disease detection and prevention, and what harm it cost you in terms of additional costs to society, plus a cascade of harmful medical interventions that over cost effectiveness. So, the effectiveness of genome sequencing in everyday people. That's a huge question, don't you think? That question of every other item in the bag. That question of every time a doctor does something to you and every is taken. All right, but we're asking that question of everything. So let's go to genetics. Docs learn. Do they do? They order stuff, right? And here's some examples of some mutations that were found in ostensibly healthy people. You know, Romano Ward is a sudden cardiac death. Not the greatest thing to hear about. You're probably going to order you. Here is somebody who had a porphyria, which is, has to do with a metabolic condition. And here, another metabolic condition, they ordered some blood tests to try to figure this out. We haven't really seen a lot of opportunity for harm or benefit yet, but of course you would imagine that would happen, either would happen over time. But we are able to start tracking what this is costing. And even these primary care docs with their one-page report takes them more time, and it costs more to the medical establishment to follow up on these tests. So we're starting very early days to try to figure out what are the harms and what are the costs. Now, if you believe, I don't know how many people raised their hands are still convinced, but if you believed you wanted this in yourself, you're all adults, how many would want it for your newborn babies, right? Let's say if you have a baby, or if you ever expect to have a baby, or if you can imagine having a baby, I think that covers it. How many would like to have sequencing on your newborn baby so you could determine all the possible things that the baby might be at risk for? Okay, fewer people, but some. And so we actually got funded to do something called the BabySeq project, which is to test the same question in newborn babies. And of course, the sensitivities are much higher here for all the reasons we've mentioned. And by the way, it's hard to recruit here. A little classic reference thrown in here, Scylla and Charybdis. Our Scylla and Charybdis have been, which I don't actually name in the slide in case they're listening, and fear of insurance discrimination. Because if people are fearful for their own concerns about insurance discrimination, they have no idea what the landscape's going to look like 18 years from now in that newborn baby. So we've actually had a hard time. We've approached 245 families, as of last week, 32. Well, I've already asked you if you want to be sequenced, and you're curious what other people are doing with their sequence. There's been thousands and thousands, tens of thousands, maybe hundreds of thousands of people sequenced to date, but most of them have been research. They don't get the results back. Actually still been only 100 people who've been sequenced and gotten their results back. And what are they doing with it? We started a little consortium of the studies that have been doing. George Church was one of the first ones with his personal genome project. Illumina, the company that makes sequencing machines, has promoted quietly an Understand Your Genome conference where you can get your genome sequenced and then come learn about it. We're doing this in MedSeq. People at Baylor, Mount Sinai, Lee Hood's group, Nevada, others as well are starting to sequence healthy people. So we're trying to follow up with them, and it's a great project because we're asking people, what are you doing with the information? What are your doctors doing with the information? So I'm going to leave you with that as a teaser because the data is just starting to come in. If I have another chance to talk to you in the future, I'll tell you more about that research. Let me wind up there, and thank you very much for your attention. It's a pleasure to be here.